Welcome. Today's FERNE educational opportunity discusses the Dizzy Emergency Department patient and the GRACE-3 guidelines which come to the rescue of the emergency clinician. My name is Edward Sloan. I'm an emergency physician from Chicago. I'm Professor Emeritus in the Department of Emergency Medicine at the University of Illinois at Chicago. I'm Medical Director for the Physician Assistant Studies Program at Dominican University, and I'm Medical Director for New Rose Healthcare Management, which helps the staff an emergency department in a safety net hospital on the south side of Chicago. Thank you to the EIM group, the group that initially supported my presentation of this information in December of 2022. I have no financial conflicts. I'm the FERNE President and Board Chair. FERNE has educated emergency clinicians for 2 decades in how to optimize the care of patients with neurological emergencies and injuries. What are the benign and critical diagnoses in patients with the 3 vertigo syndromes? We again note that there are 3 clinical settings. Acute vestibular syndrome is the patient with acute, severe, continuous vertigo, and those with episodic vertigo symptoms are either spontaneous or triggered episodic vestibular syndrome. And for these, recall there are 6 benign causes and 4 more serious causes. These rare and serious etiologies noted in the GRACE-3 guidelines include posterior circulation hemorrhage, Wernicke's syndrome, multiple sclerosis, a significant or severe cardiac dysrhythmia, pulmonary embolism, carotid sinus problems, and POTS, which is postural orthostatic tachycardia syndrome. What are the potential errors in the diagnosis of patients with these vertigo syndromes? If the clinician does not use timing or triggers approach, it may be difficult to distinguish the 3 types of vertigo and then knowing which diagnoses are associated with each of the 3. Another diagnostic error may occur if the HINTS exam or test is relied upon when the patient has no nystagmus whatsoever. Also, not knowing what the central signs are that would indicate a posterior circulation problem can cause diagnostic errors to be made. And lastly, using a non-contrast CT too often would be a diagnostic error, given that it is very little utility in the evaluation of patients with these 3 vertigo types. What are the test utilities of these varied tests used in the diagnosis of patients with vertigo? Let's look at the pre- and post-test probabilities when using these tests to determine whether or not the test has good utility when the test is negative. We see that the CT and the basic neurological exam are of low value even when negative. The MR exam and testing for ataxia, these are of moderate value when these tests are negative. The HINTS Plus, and the standing protocol are of the highest value when using a negative test result to exclude a central etiology for the vertigo of the 3 types in these ED patients. Optimally, the clinician should use a clinical algorithm that has the greatest diagnostic value in lowering the risk of a central etiology for patients with these 3 vertigo types, and these highest value tests are HINTS Plus, and the standing protocol. So as we look more closely at these numbers in this figure, we see that the standing protocol and the HINTS Plus are great tests. They have 95 to 99% sensitivity, meaning there are very few false negatives, meaning if a central etiology is present, it can be detected in the emergency setting by the clinician. These tests have an 85 to 87% specificity, which means there's a relatively small number of false positive, but this is okay given the fact that we want the highest sensitivity in order to rule out a central etiology in these 3 vertigo type patients. We know that the standing protocol has a negative predictive value somewhere between 0.7 and 5.7%, meaning when the standing protocol is negative, the patient has, even when the patient had a 25 to 50% likelihood of having a central etiology, this is reduced down to up to 6%. The HINTS Plus exam is even better. The negative predictive value is up to 1%, meaning even in patients who have a 25 to 50% possibility or likelihood pre-test of having a central etiology for their vertigo, this likelihood is reduced down to 1% or less when the HINTS Plus test is negative. So what are the GRACE-3 implementation potential solutions offered by the authors of the GRACE-3 guideline? What are the recommended potential implementation solutions for patients with acute vestibular syndrome? Regarding acute vestibular syndrome patients and PICO question 1 in the GRACE-3 guidelines, the potential solutions relate to HINTS training and neuroimaging solutions. What are those potential solutions? Training clinicians to do the HINTS Plus exam is essential, or having video oculography available. Admission and observation with MRI use is essential with patients with AVS who cannot be discharged home. In patients with AVS in whom a central etiology is likely and an acute stroke, thrombolytic therapy should be considered. Considered intracerebral hemorrhage, and if this is a potential cause, the plain brain or non-contrast CT in that case can be done. Also, CT can be done if MRI imaging is not possible. When MRI testing is not feasible, it is possible to medicate the patient in order to make it possible at the local institution, or to transfer the patient for MR DWI testing as needed. What are the recommended potential implementation solutions for spontaneous episodic vestibular syndrome vertigo patients? These potential solutions relate to the diagnoses of vestibular migraine or Meniere's disease and the possibility of a TIA diagnosis. So the potential solutions related to the GRACE-3 PICO question 2 for spontaneous episodic vestibular syndrome patients. Know the symptoms related to vestibular migraine. If it is likely vestibular migraine or Meniere's disease, then there needs to be appropriate referral. If TIA is suspected, then consider the Canadian TIA score. What are the recommended potential implementation solutions for TEVS vertigo patients or triggered episodic vestibular syndrome? These potential solutions relate to diagnosing BPPV as the etiology and considering central BPPV, which has previously not been discussed during our session. So in patients with triggered episodic vestibular syndrome related to PICO question 3 in the GRACE-3 guidelines, some potential solutions. Always consider HC or PC BPPV, that is, horizontal canal or posterior canal BPPV. Use the Dix-Hallpike and supine roll tests to make these diagnoses. The nystagmus seen in these tests can be very useful. If there's horizontal nystagmus, it's likely HC-PPPV, and if there's upbeat or torsional nystagmus, it is likely PC or posterior canal BPPV. And lastly, consider central causes of BPPV if other neurological findings exist, such as headache, vision changes, diplopia, ataxia, all of which would suggest some problem in the posterior circulation. What are the recommended potential implementation solutions regarding steroid treatment for vertigo patients? Regarding early steroid use and PICO question 4 in patients with vestibular neuritis, early steroid use is likely optimal, and it should be and could be started immediately with appropriate patient input and feedback, and if not, quick referral for use within 72 hours by another expert or consultant should be considered. What is the recommended treatment with the Epley maneuver for vertigo patients diagnosed with BPPV? The potential solutions regarding question 5 address the issue of an abnormal Dix-Hallpike test result and/or no immediate Epley effects if the Epley maneuver is done in the emergency setting. So the potential solutions for this PICO question: consider HC-BPPV and PC-BPPV, even if the nystagmus seen on Dix-Hallpike isn't consistent with those diagnoses. If it's horizontal nystagmus, it's likely HC-BPPV. If it's upbeat torsional nystagmus, it's likely PC-BPPV. In other words, it may be necessary to consider varied canalith positioning maneuvers, and it is often necessary to refer to an otophysiatrist for repeated therapy. If all of these maneuvers appear to be unsuccessful in moving the otoliths and getting patients to have decreased vertigo symptoms, it may be necessary to use MRI to exclude a structural cause because these maneuvers are not successful in resolving the vertigo symptoms. For more information, email me at fern.org@gmail.com. You can go to our fern.org website or find us at fern.org on our social media. We have this content posted on our YouTube channel, and it's available in the small 1-minute lectures on TikTok and Instagram. You can also find us on X, Facebook, and LinkedIn. Thank you for your participation in this educational opportunity today.